Welcome to this webinar session on wound healing challenges after lockdown. It's now time to consider advanced technology. I'll take you through how use of Accel-Heal can kickstart wound healing and chronic wounds. We start by looking at the chronic wounds and understanding the burden, and then looking at importance of accurate assessment. And then we're going to go to a question and answers section. If we look at drivers in the population currently in relation to wound healing, we have an ageing population. The prevalence of patients living with wounds is rising on average at 12% per annum. That's across all aspects of chronic wounds. So you've got venous leg ulcers, diabetic foot ulcers, pressure ulcers, and surgical wounds. And the costs associated with that are driven largely by nursing time. So the time that nurses spend travelling to and from the visit, and the time that they're spent with patients, be it in a hospital or in the patient's own home setting. The associated medication costs generally come with analgesia and also antibiotics associated with wound infection. And really, when you look at increased hospital stays, the average patient with a pressure ulcer will stay an additional 24 to 48 hours. We also know that drivers in the UK tend to be around the fact that the THIN database, which is a database of all GP interactions in the UK, and showed that we are not healing these wounds. So again, venous leg ulcers, pressure ulcers, and complex surgical wounds and diabetic foot ulcers, less than 50% of patients are healed at a year. So those patients with a chronic wound are living longer with that chronic wound, which leads to the increases that we've discussed previously. We also know that patients with complex chronic wounds have better outcomes when they access specialist care. However, access to specialist care is not always easy, nor is it always prompted at the most appropriate time for our patients, and that leads to additional complications and additional days with that wound. We do have additional challenges. We have definitely in the NHS where what we would call data rich but information poor. We have a lack of reliable local data from which to make informed decisions. So when product A is used over product B, our systems that we collect information in do not necessarily tell us how that product performs over product B for the patient, nor does it necessarily link the most prognostic indicators for informing choices. We have an increased staff turnover in the NHS at the moment, and generally struggle to recruit to nursing and medical positions, and that increased turnover is also driven by an ageing workforce. One of the biggest things that I think is driving things in wound care is that we do lag the amount of information that comes from the laboratory, from clinical studies and research, and transferring that evidence and embedding it in practice. We're very good at looking in silos at things, but across systems, transfer of information is really, really difficult. We need, as I've seen before and said before, to improve healing rates and patient experience and outcomes. And we've seen during the pandemic this push towards promotion of self-care. Now, never more so have patients been more willing to take on self-care in the field of wound care. Obviously, some wounds prevent themselves from patients themselves performing the care due to the location on the body, but most family members have been more than willing and able to take on self-care during the pandemic. But what have been the unintended consequences of COVID? We've been in a lockdown where patients haven't wanted people to enter their home, where we have been posting dressings through letterboxes, giving information via video conference with patients and their loved ones, but not all patients have access to that. And we know that there have been anecdotal reports of increases in amputation rates, for example, related to patients not seeking health advice in the most appropriate or prompt manner. And as a result, when they do seek advice, that has been too late and infection has been deep-seated that's led to an amputation, for example. And we do know that patients with diabetic foot, 24 hours can be the difference between limb salvage and limb loss. And we clearly need to do things to try and turn this sea of wounds that people are living with into healing wounds. If you look at, say, for example, one area of care that I've talked about being leg ulcer care, if you look at this leg ulcer template diagram, it's just it's a driver diagram essentially that looks at improving care to reduce the variation to patients. And it really primary drivers for that, looking at risk identification, assessment of patients, and then reliable interpretation of that assessment to impact on outcomes for our patients. So we need to look at whether our patients are at risk and whether we can implement preventative care in this patient group. And if we do see stigmata of venous disease such as staining or swelling of the lower limb, we need all professionals that are looking at patients, from pharmacists across to the GP to family members, really, to instigate preventative care with hosiery and garments to get rid of the edema and prevent the stigmata of disease. Once we have a wound, we really need to make sure that that diagnosis is correct. As said before, if we don't get a correct diagnosis, we can't hope to alleviate the symptoms for that patient, nor can we hope to match the treatment to the type of wound. For example, if you've got an arterial leg ulcer, you will want to refer your patient to a vascular surgeon to see if that can be revascularized, and your wound care may be very palliative. However, in a venous leg ulcer, you may want to be more active in debridement, in managing pain, and getting patients into compression. But generally, if things are failing, we need to think about appropriate onward referrals and making sure that we're monitoring progress for our patients. Never more so has it been important to identify our high-risk patients. I've listed here some of the factors associated with our high-risk patients, such as obesity and heart failure, age, diabetes, obstructive disease, immobility, heart failure, and chronic kidney disease. Not all patients will have all of those factors, but a patient with any of those factors will be at higher risk of failing to instigate that wound healing triggered system via their immune system to get the wound to heal. The other things that are related are around the wound itself. So the location, the size, and the duration of presentation will be good prognostic indicators as to whether that wound will heal. And if the patient has had prior ulceration or infection or other wounds and other wound types or autoimmune diseases, they will be at a greater risk. There are other risk factors, of course. We've mentioned the pandemic and the increase in chronic wounds and the reluctance of the public to open their house or seek help from secondary care providers. They don't want to be at risk of COVID and often see caregivers as the vectors for getting COVID or bringing it into their house. We know that elderly patients have been sometimes in the shielding population, and they have become very isolated, and their expectations and engagement and concordance with treatment may have suffered as a consequence consequence of that shielding and loneliness that comes with that. And their motivation to go out and seek help will be somewhat limited by the pandemic. And the obvious other things, as mentioned before, are things like the potential for seeking help at a later stage when it's much more difficult to intervene with a positive outcome and prevent, say, a limb loss or an amputation. We really do need to measure success in wound care, and we need to have some idea of what we're looking for. And if we are using new technologies like AccelHeal, it's really important to measure our outcomes. And is it the end result and the impact on the patient we're looking after, or is it parts or steps in the system, and are they performing as planned? So are we looking at our colleagues and whether they can use it and feel confident in using it, or what is happening in the wider system? And I think the consequences and impacts of what is happening in the wider system at the moment as a result of the pandemic have been multifaceted, and we are yet to understand the full impact of that as far as wound healing is concerned. If you look at prognostic indicators with regards to wounds, it really is a wound volume or area reduction week on week you're looking for. Generally, if you see about 40% reduction in wound size at week 4, you are going to be on a trajectory towards healing. If you're seeing the wound stagnating at any point after that, or during that first 4-week window, you really want to be thinking, have I got this right? Is the diagnosis right? Is the treatment I'm using right? Or are we seeing the early signs to chronicity where I need to use an advanced technology to kickstart healing? We need to acknowledge the factors that affect healing, as discussed on the previous slide. And we need a recognition that we need to have an accurate diagnosis and be able to differentiate between inflammation, which is common in chronic wounds, and local and systemic infection, which may well need an antimicrobial or increased dressing changes to really get on top of that infection in that wound bed and reduce the bioburden to promote healing. We need to be aware that various medications that patients take can affect healing, and we need to very much be aware of the patient priorities. What is important for your patient? Systems such as AccelHeal can have a huge impact on reducing patient pain. And as I've mentioned before, getting on top of a local infection can reduce exudate, and odour associated with exudate and wounds themselves can have a huge impact on the patient. And we need to try and optimize our patients as well by speaking to them about comorbidities and such as diabetes, and optimizing their glycemic control, or if it's immobility, using their calf muscle pump, for example, to facilitate venous return and improving their exercise capabilities and tolerance. However, if a patient's in pain, they will not want to do that. So again, in the later part of this presentation, you will see colleagues who have used AccelHeal to reduce patient pain and thereby enabled them to get into therapies that will promote healing. And the device itself has kickstarted healing for those patients. And it's important when we're looking at new things to look out for our gobs, I've put here, but that's glimmers of brilliance. So we've talked about collecting data and analysing it, but it's really important to celebrate success and share that in our next steps. Share those successes at our safety huddles, looking at the next steps for those patients, and encouraging patients when things do go right. It's really important to get that feedback mechanism for patients, encouraging our colleagues to share with other colleagues at safety huddles, handovers, and presenting. And that's what some colleagues are going to do in the next few slides. So I want to know how you plan to transform the care of your patients with chronic wounds. This is a quote from Buddha. but generally patients remember how you made them feel. How are you going to transform the care of your patients? And what are you going to do and take away from this session about AccelHeal? I'm going to hand over to my colleagues who will take you through some case studies, and then I urge you to make a pledge about what you will do to improve the outcomes for your patients with chronic wounds. It's now my pleasure to introduce Liz Oben, a tissue viability nurse specialist who will be our first speaker today. Liz was one of the earliest users of this technology and will provide an introduction to it and review the outcomes in one of her case studies.
Hello, and thank you for joining our webinar today. And thank you to Jeanette for that extremely interesting presentation about wound healing challenges after lockdown and how we can actually move forward to changing the way we manage chronic wounds in the future with advanced technologies. And I indeed fully support the pledge to do something different to break the cycle of wound chronicity and pain for our patients. So my background is in district nursing. My name is Liz Ovens and I'm a leg ulcer specialist and a tissue viability nurse. And I was the lead tissue viability nurse in the North London Community NHS Trust for many years. So I actually started using AccelHeal about 8 years ago for patients with non-healing wounds. These wounds were non-healing despite best practice. Many patients were under vascular or dermatology, but we weren't able to move forward with their wound progression. So I started using the therapy and quite soon started to actually notice the effects not only on healing, but also on reduction in pain. So I then started using it both for pain reduction and for kickstarting chronic wounds to heal. So I've been using it on a variety of different wounds, including venous leg ulcers, arterial ulcers, rheumatoid ulcers, pressure ulcers, and surgical wounds. And I would estimate approximately 90% of my patients have benefited from the therapy, ranging from complete healing to reduction in wound size, to reduction in pain and reduction in exudate. And many patients have actually. There's been previous webinars where the science and general evidence for electrical stimulation has been presented, and these are available on the AccelHeal website. So AccelHeal is a one-off 12-day electrical stimulation therapy, and it comprises of 6 small battery-powered single units. And each unit delivers an automated program of subsensory electrical energy over 48 hours. And it's designed to stimulate wound healing and reduce pain. It can be used alongside standard therapy, including compression therapy. It is pocket-sized, so it's very discreet, so it doesn't hinder the patient's mobility, and also it can be used and changed very easily by the patient. So I'm going to just demonstrate to you one of my case studies. There are several case studies available on the website. I've chosen this patient today because she actually had an arterial ulcer, which was very painful, and also it actually progressed to healing before she had any vascular intervention. So she's a 75-year-old female with recurrent foot ulcers to the dorsum of the right foot, and these have been present for 4 months by her podiatry brother. She had a past history of bilateral varicose vein surgery, hypertension, rheumatoid arthritis, osteoarthritis, varicose eczema. She was a smoker. She had quite poor mobility, poor ankle movement and clawed toes. She had quite a lot of allergies, particularly to penicillin, elastic, latex, adhesive dressings and antibiotics. And she was a bit unconcordant to some options regarding treatment and particularly for analgesia. So she had 2 wounds measuring approximately 6 centimetres square with 100% of dry, devitalized yellow slough, which was quite punched out. And you can see on the wound there, it's got thickened rolled edges, which were non-advancing. The peri-wound skin was very dry, and she had quite a presence of keloid scarring as well. Her pain score was 8 out of 10 on the visual analog score. She had a reduced ankle brachial pressure index with dampened sounds, and referral to the duplex vascular team for duplex actually determined a significant stenosis in the superficial femoral artery, and she was added to the waiting list for angioplasty. Now, this time she actually declined having any AccelHeal due to other health conditions. She declined any smoking cessation, and she also declined any debridement, which she just could not tolerate. So we actually commenced some gel dressings with the aim to try and rehydrate the wound bed and reduce the pain, which initially it did. It came down to 4 out of 10, but the pain still gained back up to 8 out of 10 a few weeks after that. So about a month later, she did consent to having the AccelHeal therapy. The wound dimensions were actually unchanged at this point, remaining at 6 centimetres square, and the pain was also again back up to 8 out of 10. Within 5 days of commencing the therapy, the pain score was reduced to 0 out of 10. Now, we were a bit concerned about this lady's skin in terms of her previous allergies to adhesive dressings. So we did continue twice weekly dressings in order to keep an eye on her skin. But actually she had no problems to the electrode pads at all. And you can see on that lower picture there that following the 2 weeks therapy, the wound has considerably improved. And following 8 weeks of therapy, the wound completely healed. She was very delighted with the therapy because it had healed the wound even before she'd had vascular intervention. And she went on to have her angioplasty the following month. So just to give you a few little ideas around who to use these therapies on, there is an AccelHeal pathway available on the website. So just consider using it for patients whose wounds have not reduced in size by 20 to 30% using standard practice after 4 to 6 weeks. So thinking back to Jeanette's presentation where she was considering alternative therapies if the wound's not reduced in size, when you would think it should be doing that in the healing trajectory. Consider using it for patients with pain who are unable to tolerate recommended treatment options. And I've in fact used it quite a lot for patients who can't tolerate either any compression or certainly who cannot tolerate high compression therapy. And patients generally with uncontrolled pain, even if they're tolerating their therapy, I've used it for a couple of patients with rheumatoid ulcers with very good benefits. So I've explained it's an easy to use therapy to kickstart your wound healing, and I urge you to consider using the therapy as part of your pledge to reduce the number of chronic wounds in our population. And thank you for your time today, and I welcome any questions at the end of the webinar. Thank you.
Thanks, Liz, for your presentation. I would now like to introduce Kiernan, a senior podiatrist from Ireland, who will share the results of an evaluation completed on diabetic foot ulcers within the acute setting. Over to you, Christine.
Hi everybody, this is Christine, and I'm just going to go through a quick presentation of a study we carried out between September of 2018 with finishing up our final data collection in February of 2019. So what we were looking at is we used the Accel-Heal unit to look at a number of diabetic foot ulcers. So a lot of the patients that we actually used in this particular study were kind of what you would call end of the line. So they were chronic diabetic foot wounds. Many hadn't responded to a lot of conservative treatments. So we used this opportunity to just see if we could add an adjunctive clinical treatment. So we'll just run through this now very quickly. So for those of you not familiar with using AccelHeal, it's basically an electrical stimulation wound therapy unit, and where sensors are placed adjacent to the wound. So basically this was, as I say, designed as an adjunctive therapy to our clinical treatment that patients were receiving. So obviously patients continued to have their best dressing selection with dynamic wound assessment at each clinical session. The treatments were carried out between myself, podiatrist at the time working in University Hospital, our tissue viability nurse specialist, and our vascular surgeon, and we had a parallel study with leg ulcers going on with one of our community-based tissue viability nurse specialists who produced some fantastic data as well. AccelHeal application pack was applied for 12 days consecutively. Patients were cared for in their own home, so they were treated as outpatients, and no additional offloading devices. We didn't want to influence the result to be give additional adjunctive treatments such as offloading devices, boots, rear foot loading or forefoot loading shoes, because we wanted to purely examine the effects of this treatment. All wound measurements were recorded in millimeters at each session, and all patients completed the 12-day treatment course. Now, so looking at the results then, subject 3 had a small chronic wound, which we observed significant improvements after even one single application, with a 98% reduction in wound volume over a 12-day treatment, with full wound closure achieved shortly after final AccelHeal application. So he was particularly impressed with the results. And with subject 5, we also saw significant improvement after one application. So subject 7 showed significant improvement in presentation 2 to 3 weeks after. So this is one of the effects of the unit that we found, is that although we didn't achieve full wound closure with all the subjects examined, we did continue to notice positive effects several weeks after the treatment was applied. And as I say, subject 7 did go on to achieve full wound closure as well. So looking at the overall results, we did see a significant reduction. Now, I will stress that there was quite a small number subject sample that we looked at here as well. And as I say, it's important, I think, to remember that we didn't achieve significant results in all of our participating subjects. Certainly subject 2, who presented with significant comorbidities at the time. Although we did see an overall slight reduction in wound size, it didn't go on to heal, but there were, as I say, a lot of coexisting comorbidities presenting at the same time as well. He was treated also, he was the only patient who was treated as an inpatient, which is interesting to note as well. Now, I do know, having worked with my colleagues, and certainly my colleague who's working in the community did say that there were some significant results in the leg ulcer study as well. So it would certainly work, I think, would be very useful for future leg ulcer studies. But I would see a use for it certainly as an adjunctive treatment with diabetic foot wounds over time as well, particularly like we did once all other avenues have been explored, and we're looking for something else to kind of boost that healing as well. Our participants reported a very positive experience, particularly subject 3, who we actually brought back. So basically subject 3 presented with a dorsal foot wound, and he also presented on the other foot, on the contralateral side, with an interdigital foot wound, which was very, very slow to heal. And we did throw most of what we could think of at it, and it just wasn't responding. So due to the positive effect we'd had with the application pack on the first foot, we then decided to swap over, also to make sure that the effects weren't to chance. And we saw significant reduction, and that wound did go on to resolve after the treatment as well. So I thought that was very, very interesting to note there as well. And we did actually have 3 people asking for reapplication when subsequent wounds, because I went on, a lot of our patients were frequent attenders, and when they presented with another wound, they did actually ask for the application pack again, which is certainly a positive user experience as well. So overall, it did, well, throughout our limitations, it was a positive experience for our patients. Certainly for user experience, was very positive. And I do think it would be certainly a consideration as an adjunctive clinical treatment for future use.
Thanks, Christine. That was a brilliant presentation. It will generate some questions for the Q&A that we have at the end. It's now my great pleasure to introduce Nicola Turner, who will share the results of an evaluation on venous leg ulcers completed in a large community trust.
Hi, my name's Nikki Turner. I'm a specialist tissue viability nurse at Midlands Partnership Foundation Trust, and I have evaluated a device known as Accel-Heal to improve wound care, improve outcomes, and improve quality of lives of the patients that I look after. The cost of wound care is astronomical, with an estimated £1.94 billion in leg ulcer treatment alone. We definitely need and desperately need more effective, cost-effective treatments to be used to improve outcomes for patients and also clinicians. The AccelHeal is an electrical stimulation device. It's proven effective in previous clinical studies on leg ulcers to stimulate healing and reduce pain. And to be an adjunctive therapy to promote healing and reduce pain in complex wounds. The evaluation took part in a large community NHS trust, which served a population of 1.1 million patients. Of those patients, 19% were anticipated being over the age of 65. The patients that were chosen for the study, we chose 17 patients that had 19 wounds, and the average age of the patient chose reflected the age of the population at being 66. Of those patients, 16 had a venous leg ulcer, 1 had a mixed etiology ulcer. The average duration of the wounds were 29 weeks, with the average pain score being 6.9 out of 10 at the start of treatment. The average size of the wound chosen was 12 centimetres squared. We started the treatment, and it runs over a 12-day period. The device is changed every 48 hours. Throughout those periods, the nurses using the devices, the patients looking after their own wounds, and relatives and care staff supporting the work patients found the device to be easy to change and very, very simple and comfortable. No detriments were reported. After the first 2 weeks of treatment, we evaluated the outcomes, and we discovered that the pain that the patients reported was reduced by 83%. So from a mean score of prior to treatment of 6.9, it actually reduced to 0.9 out of 10, and that's within 2 weeks. That's really, really significant and very, very encouraging and positive. Most importantly, it was important for the patients to improve their quality of life, with one elderly lady reporting being able to share a bed with her husband, again, which she hadn't been able to do for substantial time because the pain had caused her to toss and turn, disturb him. It fell from 74% to 32% of high exudate. Again, that's massively significant with regards to quality of life. It meant that patients could then go out a little bit more, they'd be more active, could start participating in daily life. As a clinician, we know that exudate is detrimental to patients mentally. They fear odour, strike through, discomfort from wearing heavy bandages and big pads. So this was really, really good news for the patients that we chose. We continued to use the device and evaluate it, and we evaluated for up to 20 weeks. At the end of the 20 weeks, we took stock, and we were really, really pleased with the results that we'd obtained. 84% of all the wounds were chosen actually healed within the 20-week period. 100% of all wounds which were actually less than 1 year old completely healed, which meant that the healing time was 7.5 weeks. We also discovered that pain significantly reduced further, down to 0.3 out of 10. One patient needed morphine, and also it meant that a gentleman that worked was able to go back to work. He got bills to pay, he was a provider. That improved his quality of life no end, improved his mental health, was really, really good. We also discovered, looking at the figures, that we required fewer nursing visits as a result of the reduced exudate. If we hadn't gone on to try the AccelHeal device, we would have estimated 1,208 community visits would have been needed for these patients. But with the use of the device and the way it worked, it reduced the visits down to just 338, which was 74% reduction. Again, when you're looking at the figures, that's a massive impact on finances to the trust, and improvements to patients too, and the district nursing teams. So the savings in nursing and dressing costs over this 20 weeks was estimated at being close on £40,000, £39,760, which that's significant. So to conclude with the evaluation that we did then, we found it was an effective treatment. All the patients had improvements. So they had reduction in wound size if they didn't go on to heal fully. Their pain was reduced or diminished completely. They had reduced exit date, and most importantly, they had improved quality of life. The majority of wounds healed within the 20-week follow-up period. This meant that there was fewer costs incurred to the trust as fewer nursing visits were required. And all clinicians using the treatment expressed 100% satisfaction with its use, the application and results. Since completing the evaluation, I've gone to prescribe it 6 to 8 times further on other patients, and all the patients have reported how easy it is to use, how comfortable it is, pains further, we've achieved healing, and all in all it's very, very positive. I'm very pleased to have been involved with the evaluation and to be able to share this with you. Thank you very much for your time.
Thanks, Nicola, for sharing your study and the results you've achieved using AccelHeal in venous leg ulcers. Last but not least, I'd now like to introduce Gisha, a wound care specialist based in the American hospital in Dubai, who will share recent results and successes of using AccelHeal with hard-to-heal wounds.
Good evening, everyone. I hope you're safe and doing well during this pandemic situation. Myself, Gisha, I'm a wound care specialist nurse at American Hospital, Dubai, UAE, United Arab Emirates. So about me, I have 15 years of experience in managing the complex wounds, and my special interest is in managing the chronic pressure injuries. I wanted to give you, share my experience about AccelHeal. I have used this AccelHeal to help to kickstart the wound healing process, especially in the chronic complex wounds, and shorten the healing time for this type of wounds. I've seen great results with combination of negative pressure wound therapy and AccelHeal together. In some cases, my colleagues have questioned or challenged me, okay, how AccelHeal will work. And I've tried it on wounds on the limbs, vascular ulcers and all, and they've seen tremendous change in the recovery of the patients. Okay, so I'm just going to explain you one of the cases that I have done it very recently, and I'm just going to share with you my experience. Yeah, he's a 57-year-old paraplegic man transferred to us with pressure injury stage 4 on the sacral area. He had multiple pressure injuries on his both trochanters and on bilateral heels also. At another facility before coming to us, they have done a sharp debridement, a good sharp debridement. Then they did not do any advanced wound dressing. They were just doing the wet to dry dressing. Okay, and when he came in, he was in a bedridden status. He was obese. Diabetes mellitus was there. Incontinence. Then they were using only traditional dressings. It's a deep wound. He's not a candidate for any surgical procedures, because normally in this case you could take the patient for a flap reconstruction to close the wound fast. But then because he was on tracheostomy, oxygen dependent, he was on anticoagulants, a lot of other things were going on. So he was not as good candidate for surgery. So we decided we will do wound management in a way at the bedside itself. Okay, no other intervention will do. So if you see the picture, it's a pretty big wound, and then our aim at this phase was to promote complete wound healing as early as possible and to prevent any wound infection, because it's a pretty big wound here. Patient developed this wound over 3 months of time. It was a facility-acquired pressure injury. When I got this patient on 24th of August, 2020, when upon admission we measured the wound, and it was like length 11 centimeters, breadth of 12 cm, depth 6 centimeter with undermining at 5 o'clock position, 5 centimeter to 11 o'clock position. As you can see in the picture, the yellow mark I've put it there was our undermining 5 centimeter. The wound initially was cleansed with superoxidized saline, and immediately we started with negative pressure wound therapy, continuous mode at 125 mmHg with silver forminant. Change of dressing was done every 3 days. AccelHeal was introduced after the third day because it was not, I did not get it immediately at the bedside. So we had to order it and we got it on, we applied it after 3 days. Means August 27, we started with AccelHeal. Yeah. So after applying the AccelHeal, what I have noticed is there was an increased exudate after the application, because the nurses started speaking with me saying that every 12 hours, 24 hours, they ended up changing the canister. Why I put on continuous mode is like patient was coming from another facility, there would be colonization. So just wanted a good cleanup of that wound. 1st September, we changed the dressing again. The wound measured length is 11 centimeter, breadth of 8 centimeter, and depth of 4 centimeter. The wound bed is, you can see it's fully granulated. Exudate is minimal after 3 days. Continued with negative pressure wound therapy, but this time I changed to black foam on intermittent mode. For your more information, this is have taken the measurements. Okay, that was on 24th of August. Then post AccelHeal, as you can see in the picture, treatment period was from 27th August to September 19th. The wound healed from a length of 11 centimeter to 5 centimeter and breadth 12 to 4 centimeters. When you say breadth 12 to 4 centimeter, you need to see here, because the anal area is over here. I couldn't place the electrodes over there, so I placed the electrode at 3 o'clock and 9 o'clock position. Okay, 3 and 9. Always the electrode were placed on that way. That's why probably the breadth became so short from 12 to 4 centimeter. I think that was the reason probably. Depth came down to 2 centimeter, and there was no undermining at all at this phase. Okay, excellent progress was noted, but I couldn't complete the case study because the patient had to go back to his own home country. He was visiting us for a rehabilitation part, and he got rehabilitated slowly, and then they felt like they are safe to go, and they were scared of the lockdown that may come, so they wanted to go back as early as possible. So I couldn't get it completely closed by this time. So the clinical routine that we have followed is, it can be used to start the healing process as an adjuvant therapy, along with standard wound management and negative pressure. It's an early experience in the Middle East so far, but I have seen some incredible results with very challenging cases. Tips and tricks I could explain to you is, it doesn't increase exudate, as I said. Then once the inflammation was suppressed, probably that could be the reason. And then the length of the electrode was, it limits for a sacral wound. If you say the wound is quite big, right? So when you place the 2 electrodes on both sides, that length was a bit shortened for me. And our plan is to use it on a graft donor site for the healing process actually. And I found something really interesting in this is, I could use it outside the box as a communication tool for the nurses, so that every 2 days when you change it, when you see the box, the nurse will know that, okay, it's time for me to change it. This box was used for another patient in month of February. That's why you see the 2nd month is there. But again, always I put these notes on the box so that nobody will miss it. Okay, and then always remember, this is an adjuvant therapy. You have to follow your nutrition, wound management guidelines. Incontinence, patient had incontinence. That was another challenge. So we had applied indwelling catheter for him. And then offloading, definitely, if we don't offload, these wounds will not heal. So, and you could shorten the healing time with all these advanced wound management techniques. And then please follow the pressure injury prevention protocol as always. And if you follow all these things, easily you can heal the wound at an early phase itself. Okay, that's my experience. I hope you enjoyed it. Thank you.
Thanks to all of our speakers today for sharing their case studies. I'm now going to open up the question and answer session, and we'll do our best to answer all of your themed questions. And all of the speakers are here to share their thoughts with you.
I hope everybody enjoyed that, those presentations. I've now got the pleasure to open to our questions. We'll do the best we can to answer as many of the questions as we can for you. So I'm just going to start with, there's been a question about self-care during the coronavirus epidemic. and the question is it easy to use by patients and carers themselves? So I would say it is, yes, in my experience. Liz, do you have anything to add to that?
Absolutely, it's easy for patients, easy for carers, family members. It's a very easy device to use. Yeah.
Do any of our other speakers have any comments on that?
I'll comment if that's okay. So we found in our study that patients who were in a position where they had support and help at home, once they were shown how to use it, they managed quite well. So we found that actually had a huge influence whether they had somebody at home to assist them, because it was a little bit awkward with the battery and the dressing changes. But yeah, we didn't see any significant problems. No.
In my experience, it really depended on where the wound was, but patients can generally use it themselves. And there is obviously coming out of our Australian colleagues to suggest that being involved in the self-care of a patient's wounds is actually beneficial from a quality of life perspective. So there's a question for Gisha. When using AccelHeal with negative pressure, what do you see as the additional healing response compared to negative pressure alone, Gisha?
Okay, so it's a good question. Whoever asked this question, thank you. So we have seen it's a good kick-starting method to help for the granulation of the tissues of the wound. Okay, such a big, deep wounds, when you start with a negative pressure wound therapy, there's a risk of getting the wound stalled. Yeah, so you basically wanted a kickstart of that wound at that point. So if you combine negative pressure along with AccelHeal, you can see the healing time is faster, and it will help to reduce the pain at the same time. Some patients may not be very compliant with the pain when you start with negative pressure wound therapy, especially on the lower limbs. They will ask you to stop the negative pressure. So it's like a disadvantage for you at that point. Oh, you ended up stopping the treatment. But instead of that, if you combine along with the AccelHeal, you will see the pain is released. There is good compliance from the patient side with the negative pressure, and at the end point, you can have a great healing in a short period of time. Yeah.
Thanks, Gisha. Liz, I think you had noticed also about reductions in pain with your patients. So you're able to comment and add to that? That's a great point.
Yeah, I think that the pain was really what was quite a surprise, really, from when I first started using it quite a long time ago. And I think it's reflecting what everybody else seems to be finding, I think, in their clinical experience of using it. I've seen pain reduction as soon as within that same evening of application, where the patient actually omitted their tramadol. But certainly within the first few usually by the first dressing change, I've seen a pain reduction, and it seems to continue on after that as well. I think Nikki sort of pointed that out. Even sort of after therapy's finished, the pain continues to reduce. So yeah, that's.
Would you like to add something to that? Because I think Liz was referring to your work there.
Yeah, we found it was really, really beneficial with reduction in pain, and currently we're looking at putting it on our leg ulcer pathway to enable us to put patients into compression that won't tolerate compression, pretty much what Liz said in the first instance. Yeah, patients, they were able to go back to work, reduce the medication, stop the medication in some cases, massive impact on quality of life and getting people back to normal, so they felt more like a human being again rather than a wound, which is what they do feel like. Yeah, really, really positive.
Christine, have you noticed anything in the diabetic foot population that you've studied?
It was a tricky population because of the nature of the sensors. We had to exclude all plantar wounds. But we were surprised with some of the positive results that we did get. But certainly it did actually help, and it helped actually with one person's pain levels as well, which was very good too. So that was an incidental finding that we found quite good too.
And there's somebody here that's commented that you'd achieved a 40% reduction in wound volume in the 12-day period. Christine, do you want to talk a little bit more about that? Was it used on hard to heal wounds, those wounds that were recalcitrant to start with?
Yes, absolutely. So basically, a lot of, as I say, a lot of the wounds that we had that we'd actually selected were chronic wounds, and this was an end of the line treatment therapy. So we were very careful, and I think I said this in the presentation, we were very careful not to add anything like, say, for example, an offloading therapy that would have skewed the results. But they were seen very regularly, as they would have been anyway, even if we weren't using the therapy. But we measured wound volume and size at every clinical session, and we were very, very surprised. And I think, if memory serves, that was probably subject 3 that we saw significant results very, very, very fast in.
Excellent. Have others witnessed that in recalcitrant wounds that they've managed, as well as the pain reduction, seeing that kickstart effect that we were talking about at the beginning of the presentation, which is often so important for patients? And given the current drive to self-care, I think we will see more patients that have been reluctant to come forward, potentially.
I've recently used it on a gentleman with a pressure ulcer to his malleolus that's been really, really stubborn despite offloading and everything. And we had a massive result to start with. He's become a little bit stubborn and stagnant again now. In fact, I'm thinking of revisiting the treatment again at my next review visit, which is in the next fortnight. And he has actually asked for it to have it put back on, because he had such a dramatic result.
Nikki, that ties in with one of the other questions, which is, can you use it for a second time, or is it just a one-off treatment?
The therapeutic effects do say that the companies recommend that they last for up to 12 months. And when I did my study, I did use a second device on a particular patient. So you can revisit the therapy. There are, as far as I am aware, no contraindications, but I certainly wouldn't put one treatment plan on top of another treatment plan. I'd leave it as a period of time in between, just to see if the cumulative effects go on to work.
Okay, and another question which is related is it reimbursable in the UK? So how do people get a hold of an AccelHeal product?
It's available on FP10, it's prescribable. So you just prescribe it if you're a nurse prescriber, or you get your GPs on board and your consultants.
And you mentioned that you were going to put it on your leg ulcer pathway. Has that been an easy sell to the CCG and the peers?
I'm laughing because it's been a very long battle. We're not there yet. In fact, we'll have to leave this meeting shortly to go to a medicines management meeting where I'm hoping we'll be discussing it yet again. But yeah, we are hoping to get it on sooner rather than later. It's not an easy battle.
I know in our area we managed to win that fight, but it is sometimes a challenge, isn't it? But it's really, really great when you win and you are able to use these.
I think it's because it seems such a random type of treatment. It's 2 little electrodes and a little battery pack that essentially seem to do nothing at all. But when you actually look at it and look at the evidence, it's massive, and the impact is massive.
I think the other question that alludes to that is the evidence. Liz, do you want to talk about, is there any RCT evidence?
Yeah. Well, I believe there's about 30 RCTs on electrical stimulation and several meta-analyses. So not really many people are aware of how strong the evidence is regarding the broad electrical stimulation therapy itself. There is obviously some further evidence regarding specifically AccelHeal. And that can all be found on the website. There is one RCT that was done on VLUs for using AccelHeal, and they found that the leg ulcers healed 4 weeks faster on the AccelHeal treatment group than on the placebo group. And there was also a study done on AccelHeal regarding reduction in expression of inflammatory genes. That was showing that the effect reduced the inflammatory gene versus placebo, that the effect was quite significant. And that consequently reduces the pain if you've got reduction in inflammation. So there's a wealth of evidence regarding the therapy. Yeah.
And people can access that from the AccelHeal site, can't they? I think if I had one bit of advice to give anybody in terms of that meeting that Nikki's going to, it would be to have your evidence and also to have a group of patient stories as well, because I think they can often be the deciding factors, and we know that the healthcare providers, i.e. us, are the biggest cost as far as wounds are concerned. Does anybody have anything else to add? If you were new to this therapy, what advice would you give to somebody using it for the first time? Nikki, I'll come to you.
Do your research, speak to your local representatives, access the website, and go for it. It seems a little bit of a random type treatment. To heal stubborn wounds just need that time and that attention, and give it a go. Really, it's very, very simple to use. The patients like it, carers like it. We've alluded to this previously. It's so easy to use and very, very effective.
Christine, anything from your perspective to add?
No, I agree with Nikki. I think basically, I think we have to believe in our patients and their support network, I think, as well. I think in my experience, certainly, most of the supportive care guardians we had for patients, they only had to be shown once. And once we had kind of a comprehensive format or template to sing from, everything was fine after that. So we'd no known problems.
Gisha, anything from your perspective?
I think all the new nurses can use it very easily. Just they can watch the video in the website, or else you, as a tissue viability nurse, you could just give a 5-minute talk about the how you fix the electrodes. It's very easy. Even our caregivers, the patient assistants, they also started applying it at the home. So patient doesn't have to stay at the hospital just for the treatment. They can go home and can be visited at the OPD clinics. It's easy to use thing. Yeah.
Liz?
I think the only thing to add to all of that, because I agree with everybody's comments regarding that, is just the fact that you can use it with the patient standard therapy. And I think that's really so nice that they can continue on having what, because they do get used to what they've been having and what they like, and you can actually carry on with that. And also, by encouraging them to be involved with sort of certainly changing the device itself, they, you were talking about the study, Jeanette, in Australia about self-care. It actually helps them to feel part of the therapy, which sometimes they don't when the clinician's applying the dressings and the compression, but actually by being involved in that part is really beneficial as well. So they'd be the only sort of 2 extra points I'd add to everybody else's.
There's one last question, and come to you again. There's been a question about compression, and I know you have used the therapy with compression, but the question is specifically, can it be used with compression bandages and hosiery? Yes,
it can. It can be used with, well, I haven't actually used it with Velcro devices.
Right.
Personally. I don't know if any of the other members have, but I've used it with compression bandages and with hosiery. And I've often actually used it in order to try and allow the patient to tolerate compression, because we know how difficult it is for patients into the compression that perhaps they've been previously intolerant to. So
excellent. So I don't see any other questions that aren't in relation to specific patients, which we can't answer here today because it's not the scope of the meeting. But AccelHeal will put all answers to all of your questions if we haven't answered them on their website. And I'd like to thank all our speakers, for AccelHeal for putting this on, and Spark for hosting the event. And I'll bring the session to a close. Thanks, everybody.
Thank you.
Thank you.
Bye. Thank you. Bye. Have a great day.
You too. Bye.
Bye.